Important to know the structures responsible for varus stability, valgus stability, posterior stability, and posterolateral stability of the elbow. This has been discussed before. There are mainly two theories proposed for mechanism of injury. One is the valgus external rotation theory proposed by Osborne and Cottrell and developed by O'Driscoll in 1992. The other one is the valgus hyperextension theory, where the medial structures are primarily involved, whereas in the Driscoll's theory, it's the lateral structures. It starts from the lateral and goes on to the medial side. So this has three stages in creating instability. Stage 0 is normal, reduced elbow. Stage 1 is LUCL injury with instability but no dislocation yet. Stage 2 is, in addition to stage 1, the radial collateral ligament, anterior and posterior capsules are injured, leading to the perched elbow that Dr. Pratap was saying. It is still not dislocated. In stage 3, the previous ligaments and the capsular lesions are combined sequentially with a progressive injury to the MCL. The joint is completely dislocated, and based on increasing severity to MCL involvement, it's further divided into three stages. 3A, where only the posterior MCL is involved, but the elbow is stable in pronation. Stage 3B, the anterior and posterior bands of MCL are involved, and it's grossly unstable in valgus. Elbow is reduced by avoiding the last 30 to 40 degrees of extension. And stage 3C, where there's complete stripping of the soft tissues, including tendon origins of, from the epicondyles, and the elbow is grossly unstable except when flexed more than 90 degrees after reduction. This is difficult to hold reduction. And dislocations are divided into simple with only the soft tissue or ligamentous injury, complex with associated fractures, and complicated with other complications. And there are, as we have seen, three main theories. One is the Driscoll's theory, the other one is a medial theory, and the third one is a combined, the global theory. 20% of simple of dislocations are stable simple, 40% are unstable simple, and 40% are complex dislocations. And surgery is indicated in irreducible fracture dislocations, unstable dislocations after reduction, and associated fractures requiring fixation and stabilization. Algorithms have been proposed for managing acute dislocation. After close reduction, the elbow is assessed for stability. Look at how much extension the elbow redislocates in. If more than 30 degrees, then it is unstable. If stable, a dynamic brace may be given, and if unstable, under 30 degrees of extension, ligament repair is performed. For stable elbows, a range of movement brace can be provided and locked at 90 degrees and can be discontinued at 3 to 4 weeks of rest, and 4 to 8 weeks for activities. Shoulder abduction should be avoided because it creates a varus moment for up to 3 weeks. The problems with conservative managements, there have been some reported. 60% have residual symptoms of pain or stiffness, not feeling the same as the other side. 45% have pain, 15% have flexion contractures, and recovery takes a minimum of 6 weeks. Arthroscopy has been reported to be beneficial in the primary management of high demand patients. Findings in this include bare area of the radius, easy drive through to medial side and loose annular ligaments, and a positive pull test. So that is when the hand is pulled down, a gap appears between the radial head and the capitulum. So they have reported 15 consecutive patients with quick recovery and 100% return to play. Before open repair under anesthesia, give valgus stress in supination to test medial ligaments and varus stress in pronation to test the lateral ligaments. Running stitches may be taken through the lateral ligament and fixed to the isometric point. We have seen images before of the humerus, and because the humeral side is the most commonly injured, it is repairable. Repeat examination after repairing the lateral side to check for the medial side. If that is also injured, reconstruct or repair the medial side. If it is unstable even after that, then an external fixator or a K-wire may be used. There are a plethora of classifications for fractures of the elbow, of bones around the elbow, and some surgeons use these to classify depending on the bone fractured, but it does not give us the full picture of instability. If you need a classification which combines instability or dislocation with fractures, there's one introduced or reported recently from Wrightington, published by Adam Watts. They've divided into 4 groups, A to D, and they divide the elbow into 3 columns, medial, middle, and the lateral column. All these have a lateral ligament complex injury, and management in all will require lateral ligament complex repair. Type A is the medial column injury involving anteromedial facet fracture. There may be avulsions of the lateral ligament complex in the posterior band of MCL. Treatment is by fixing the ligament, fixing the fracture, and fragments, the facet fragment less than 5 millimeter may be ignored. In type B, it's a bifacet fracture, and it involves 2 columns. If you see, the injury moves from medial to lateral. So the columns are middle and medial, and these are apex anterior Montagia fractures. And these are treated by the ligament fixing the fractures of the proximal ulna. B plus is a bifacet fracture with fracture of the radial head. These are most unstable because 3 columns are injured, and they can be apex posterior Montagia. This is treated by fixing the ligament, fixing the bones, and restore bony stability. And rarely, MCL and common flexor origin also would require repair. Type C injuries include terrible triad, lateral and middle column injuries. They involve the lateral ligament, MCL anterior band, radial head, and the treatment is by restoring length of the radius. Anterolateral facet may be ignored, and X-fix may be used for medial laxity. Type B are lateral column injuries involving the proximal ulna, dislocated radial head, but it's intact. It differs from type B by not having a facet fracture. These are treated by radial head reduction and plating of the ulna. D plus are lateral and middle column injuries like apex posterior Montagia. Here the radial head is frequently fractured. Treatment is by radial head replacement, maintaining the length, plating of the ulna, and the lateral ligament injury. So this is an overview. All injuries have lateral ligament injury and need repair or reconstruction. For anteromedial and bifacetal injuries, the coronoid fixation is advised. Where radial head is fractured, it is advisable to fix or replace. Excision is not recommended in association with instability. So distribution of fractures with dislocation is shown here. Important to note the finding of osteochondral injuries during surgery is almost 100%. So complicated dislocations have 1 or more of these associated complications. Open dislocations are managed along lines of open injuries and principles of dislocations. Montagia and terrible triad we have discussed. Osborne cortical lesion is a rare lesion where there is avulsion of the where there is impaction fracture of the posterior capitulum and the radial head, and it can dislocate with this. So SX low-presti injury is acute. In acute cases may be managed by fixing the distal radioulnar joint after reduction with K-wire and manage elbow along principles we have discussed. And it's very important aspect to not excise radial head in these cases. If excision is required, replace head and maintain the length. Ulnar and median nerve injuries have been reported. It's important to reduce the joint. Brachial artery injury has been reported. Lateral ligament injury could occur during lateral exposure to elbow through cocker incision. So it is important to take care not to injure when you use a cocker incision. K-wire may be used as an option when external fixation is not available after other ligaments have been surgically stabilized, but it should not be used as the only stabilizing force. We have seen this being reiterated today in many lectures. So complications are recurrent instability, hypertrophic ossification, stiffness, nerve injury, arterial injury, contracture, and arthritis. To summarize, acute elbow dislocation is a common injury. Lateral instability is most common mechanism. Conservative mechanism management is the gold standard for all low demand patients. high demand patients may benefit from an early repair of lateral ligament. Complex dislocations are assessed based on the type of injury and repair bony and soft tissue restraints to stabilize the elbow, identify complicated dislocations for optimal outcomes, and avoid prolonged immobilization to prevent stiffness, which is one of the major complications with these. Thank you very much.